So Pacritinib is a JAK2 FLT3 inhibitor that we presented before the PERSIST-1 study that was randomized Pacritinib versus best alternative therapy in individuals that were JAK inhibitor naive, allowing any level of platelet count. There were very favorable results. However, there was excess mortality on that study, and it was difficult to know whether that was associated, the mortality was due to adverse patient selection. It was a 2-to-1 randomization, just a third on the BAT arm, a lot of patients with very low platelet counts, very advanced disease. PERSIST-2, which is reported here as a late breaker by my colleague John Mascarenhas, a trial I and many participated in, was a trial of Pacritinib at 2 different dose levels versus best alternative therapy for individuals with a platelet count of less than 100,000 who did not have to be necessarily JAK inhibitor naive. With that, we identified several things that we report out at this meeting. One, the Pacritinib 200 milligram twice a day dose seemed clearly superior to best alternative therapy in terms of spleen response, improvement in symptoms, as well as safety and likely survival as well. The 400 Q-day dose of Pacritinib was not as favorable. It trended to be favorable, was not as favorable as the BID dose compared to the best alternative therapy. Some of the toxicities or concerns that had been raised by the clinical hold on PERSIST-1 do not really seem to be echoed to a great degree in PERSIST-2. However, there does seem to be some slight safety advantage to the 200 BID dosing. So one, overall, the data were favorable. 2, there does seem to be some differentiation really regarding a dosing strategy that hopefully in aggregate will allow a path forward for this agent to become a resource for MF patients.